this is a focus on supplemental benefits, and we couldn't have 3 more experienced, knowledgeable people in that space and the value that it provides to seniors. It'll sort of go into other areas, but we thought we'd start there. But Ipyana?
Sure. So I am pleased to represent Meals on Wheels America, which is the leadership organization for senior nutrition programs around the country. We provide nutrition and social isolation support to seniors across the country through the work of our more than 5,000 plus programs.
June?
I'm June Simmons. I'm a founding CEO for Partners in Care Foundation, a not-for-profit in Southern California that helped pioneer the community care hub concept, and both a provider and a change agent. But I have a second job, which is that I'm the co-chair of the Partnership to Align Social Care, which advances that community care hub and is cross-sector co-design for the alignment of social care and health care nationally.
Hi, I'm Bob Blancato, and I'm happy to be here for Gender Balance. I'm the Executive Director of the National Association of Nutrition and Aging Service Programs, which works as Meals on Wheels America on behalf of folks providing meals to older adults, both in congregate and home-delivered settings. And as our name suggests, we also focus on other aging service programs in doing advocacy.
Thank you all. And you'll be able to tell from the discussion, these 3 are not meeting for the first time on this panel. And again, having worked with each of you on supplemental benefits, I'm going to sort of start with a bit of a challenge that we've had, is that there's been a narrative around supplemental benefits that they're these luxurious benefits, and do they really provide value, and how do they lead to positive health outcomes? And it would be sort of a helpful place to start to see what we need to be doing to try to change that narrative with policymakers, because we're also at a time, and I kicked off this morning, which now seems like 14 hours ago, where it was just the Medicare Advantage program in general is under fiscal pressure with the aging population and with all these policy changes, and the supplemental benefits are an area that is being looked at and in some audiences scrutinized. So just to be able to get your expert advice on what we can be doing to in both education and advocacy to help change that narrative.
So I think,
and I'll take turns on who's going to start first, so Ipyana's not going to feel like she has to answer first every time.
So I do think that the term supplemental does imply that it is additional, not needed, can be without. But I think for the work that we do and the programs that we represent, I don't think any of us would think that food is supplemental to anything that we do. Social support, having people that can monitor our well-being, I don't think any one of us would view that as being supplemental. And so I do think that telling the stories of the work that our members are doing is crucial, because I do think that there is an assumption that people can do without, or it's someone else's responsibility, especially when you're thinking about a population like seniors. I think when people think of services provided to children, they feel like, okay, we need to provide that support, that infrastructure for their meals, for their various services to be delivered. No one thinks about that with respect to seniors. They figure seniors are older, they have the resources, they work, they have the ability to do all these things and take care of themselves. And that's just not the case. We aren't the communities that we used to be. We don't have the services that we used to have. And health is definitely not something you can take for granted as you get older. And so as we need more help navigating the complexity of these systems, we really need to make sure that people understand that the supplemental is not really supplemental. It's actually really integral to our normal health and well-being.
Nicely put. We are seeing an interesting evolution, especially in the new physician payment rules out of CMS, and there is an effort to advance care coordination around social factors that drive health outcomes. So driving coordination is great, and that can be paid under the usual healthcare benefits. But we like to say there's a problem if you're all assessed up and know where to go. So if you identify these social needs and you don't have a way to pay for some of the most critical, as you're noting, so this becomes then an essential piece of the pie to really, pardon the pun, to really address the factors that drive health-related social needs and that really impact population health in a significant way. So I think it's going to transform and that will be very valuable. But I also think, because we see a number of plans that have over-the-counter purchase allowances in the supplemental. And actually for people of low income, some of those, they're interesting to look at least some that we've seen in Southern California. There are things like soup and cereal and other kinds of goods that can help people with some of their very basic needs. So if somebody's getting, let's say in case of one of the health plans, I don't know if we should name health plans or not, Scan Health Plan has like a $600 a year benefit. That's pretty meaningful for some people, especially if they're duals, but a lot of people live close to the edge these days. So I think there are a lot of ways that the supplemental benefits can be quite meaningful in these days of economic peril that many people are afraid of running out of money and needing basics.
I want to go back to Ipyana's point about the name and the words. You know, words convey meanings, right? So take our football team in Washington. They're called the Commanders. Do you think they command anybody? They won a game on Sunday. That makes them 1-1. But think about it. The term, right? Like supplemental. If you let it play, it's discretionary. It's not necessary. It's nice. You know, it has a bad connotation. So to me, that's where the process has to start. And the other part is, you know, you talk about the narrative. Who created the narrative? You know, I mean, we should be thinking about who created the narrative and go after those individuals and convert them back to thinking differently about the whole thing. That's what I would do first off the bat.
Although I like the supplemental aspect in that it's suggesting a first step towards social care and social components and key services outside of the direct medical benefit. It says there is more than the direct medical benefit, and we should add to it. So the language, I think it's a wonderful point. But still, it's a first step if we think of change as incremental.
And just one other thing, too, as we all do in advocacy, it's about the data and the stories that you can show, success stories. I mean, there was a program in Massachusetts that offered 168 meals to people for a period of weeks, and they ended up with reduced inpatient and emergency department spending in the first year. So, you know, if you have those kind of outcomes and using a supplemental benefit, you know, suddenly it has a different connotation.
That's right.
Thank you. And we do appreciate you sharing that example, Bob, because we do in our advocacy try to share a lot of different best practices. And I know you all have been a part of getting those examples to share. And I know we had Allie earlier from ATI speaking about a report that we have forthcoming. So we'll be able to both share that data, but then additional best practices around it. I think a lot of you were here earlier when Juliet Choi from the Asian American Pacific Islander Health Forum was here. We were talking about health equity, and supplemental benefits came up a lot in that conversation. And as you think about the value of supplemental benefits and the utilization, you know, do you feel that there's certain health equity principles that could be applied to guide the MA community in ensuring that the supplemental benefits are being utilized and shared with the diverse populations that desperately need it?
Okay. You didn't ask me to start, but I will.
We're going to just keep
There you go.
around.
The first thing I think you got to look at is where are the disparities? Okay. If you're an older adult, if you're an older minority adult, if you're an older LGBTQ person, if you're an older Native American, an older rural American, you've been dealing with these disparities longer. And we should be addressing them more quickly. Okay, I mean, that seemed to me the first thing. And we do have to focus more on the rural population because 250,000 rural Medicare Advantage participants don't have access to supplemental benefits. That needs to be modified and changed. And the other part of the question is you've got to work more with the communities who understand the situation at that local level, where they need to direct resources and attention. So I think all those things combined could be helpful in addressing health equity, which we must do.
That is an advantage of the supplement, I guess, is that it's versatile. You could go community by community and see what are the most critical and pressing issues to address through that more flexible mechanism.
Yeah, I do think when you talk about equity, you can't have that conversation without trust. And I think, unfortunately, there are presumptions that because you ask a question, you'll get an honest answer. And the reality is that when most doctors, I mean, I think of the question that you have to fill out on the form where it's like, how many drinks do you have a week? Most people are like, well, is that a week we had office parties? Is that a week where I was traveling with my girlfriends? Was that just a really bad week or a really good week? You know, it depends on how you celebrate. So I think it's that, we are hesitant to answer questions in certain circumstances because we're not sure how that information is going to be used.
Mm-hmm.
And I think if you don't have that recognition of if there is no trust, or if there's a feeling of, I've told you all this, the past 10 years I've been coming to these doctor's appointments and nothing has changed, I'm just going to stop answering the question because clearly you either can't do anything about it or you don't care to help. And so I think that's where the value of partnering with community-based organizations who know people in the community. They know the ways you ask a question. They know kind of the terminology. They know the language. They know, I mean, there's so many things that happen in that trusted conversation that are needed to really figure out how to address disparities in a meaningful way and not just this worked in community A, so we're going to do it in community B through C, not recognizing that they're all different and they're all nuanced. All rural communities are not the same. All communities of color are not the same. All urban communities are not the same. And I feel like, I worked at a health plan. I feel like you get something that works and they're like, oh, let's replicate, let's scale it, let's do that. That doesn't work. Mm-hmm. It doesn't work. And so there has to be that understanding and recognition that behind equity, there has to be trust. And there also have to be solutions that you're willing to hear and recognize that, oh, well, we did that there and that didn't work. Oh, so you're telling me I got to do something different now. Mm-hmm, mm-hmm. And recognizing that that's not always how health plans work. It's not always how actuaries work. Mm-hmm. And so figuring out how to get the payment, as you mentioned, because if you can't pay for it, you probably can't do it. How you get all of those things together to actually be implemented is crucial.
And let me just add one other thing is, even though for some people social determinants of health was just an invented term, they just learned about it, not in the communities.
That's right.
They've been at it for a long time. They've been running programs for 30, 40 years, addressing those very issues. And so they need to be consulted on a really aggressive basis to get to this equity issue.
We have forces that help that because there's now all this pressure on health equity outcomes and reporting, and we see accreditation, and we see the new hospital requirements to look for social factors that drive health outcomes. So I think that's our friend, although as we heard earlier in the Asian Pacific Islander National Association, disaggregated data and really differentiating because, we used to say black, brown, white, and whoever else, red, yellow, that actually, I just was reading on the plane coming here about a community that 160 languages in that community. So the diversity within diversity is also something to be enriched by, but to learn about and master.
One of the features in the Medicare Advantage program is the value of preventive care and how, again, it contributes to higher health outcomes and also cost savings. And when it comes to supplemental benefits, what do you feel can be applied to supplemental benefits that contributes to the value of preventive care that could hopefully lead to better health outcomes? And there could be some examples of certain supplemental benefits. Maybe it's nutrition. June?
You for nutrition. Well, we're beginning because we're service in California as a community care hub. So you have one agency, one community agency that goes to the trouble of inventing the business infrastructure that can do a David and Goliath contract with a large healthcare payer to be able to receive this kind of money. And so we get to hear a lot of opportunities, and one of them is food as medicine. So we see in the Bay Area, they have really great examples of the results that they achieve. But the members of the Food as Medicine Coalition, which is a very strong coalition, a lot of them are these very small, trusted, who will you let in your house? Who will you trust to give you food? And they think it'll be safe, who will speak your language or be able to get along with you. So we're working with the San Francisco Health Plan, who has a lot of people they have now identified, which is sort of broadcast news, that they've noticed that they have maybe 30,000 people who would benefit from food as medicine. So then they need a delivery system. So then they need the community agencies. So we see the evolution of recognition that if these things work, then what? First, we're going to identify these needs. Then we're going to see, oh, maybe there are solutions. Then we need a distribution and a treatment system, because this community answer is a new provider system. This is a new specialty that's missing. Social care is a specialty, I think. So I think this is exciting to see this attempting to emerge, and now we just need to make it work on a bigger scale.
Well, I think two things. One is we ought to be giving priority in this whole conversation to those people from the pandemic who delayed their care, who may need to be addressed more quickly. It may not necessarily be medical, it could be social care, but it still affects their quality of life. And
Huge.
so we have to do it. And number two, it would seem to me that any benefit should begin with having prevention as its goal. And it should be designed that way. And then you would have a much clearer nexus between the benefit and the prevention.
Yeah, I definitely think that typically our health system hasn't figured out how to do prevention well at all. We haven't figured out how to pay for it. We haven't figured out what it actually means. I think, even food as medicine. I mean, food has always been vital. Now it's food as medicine. What about food as food? And everybody needs food. And if you eat unhealthy food, you're likely to have unhealthy outcomes. And so, like Bob mentioned, all these new names for things that have been in existence for years. But the reality, like social determinants of health. I remember after the ACA, if you did a drinking game, you'd be drunk 5 minutes into any conversation on healthcare because everyone was saying SDOH, SDOH as though it was new. But everyone has been talking about these things. Everyone who worked at a community level has been talking about the integration or lack of these various components throughout, because that's why you have these hurdles that people need community-based organizations to help them navigate. So, I think we're continually reinventing terms because we're realizing with each new term, you kind of move the ball a little further and further up the hill. But the problem is that it's still not addressing the fundamental issue that prevention is actually something we need to pay for, and we need to figure out how to pay for it in a sustainable way. We figured out how to pay for drugs, and I don't know if we figured it out, but there's a way to do it. But it's in terms of figuring out, well, how do we cover nutrition? I mean, Bob, our organization's working on the Older American Act, or organizations that work with SNAP. It's the same thing. It's, those are always struggling, trying to figure out, continually going back to Congress, asking for additional funds or additional resources. But if we're looking at holistically, how do we provide continuous nutrition for vulnerable populations? That's the conversation. And unfortunately, some of these various terms or the various programs are so siloed in terms of their funding, in terms of what providers see, what community-based organizations see, that it's really difficult to move the needle in a way that's meaningful. So that if you're looking at a CMS or looking at members of Congress who want data, it's hard to show it in a way that is impactful for them. But the reality is that we know, do we really need studies that food is helpful? How many studies do we need? Really? We don't know fruit is healthy. We don't know that if you're not eating a good diet, then likely you're going to have some adverse health effects. We know this. Why do we still need more studies?
Right. And I also think it's
Yeah.
interesting how even the term SDOH, you've got some people called social determinants,
Right.
and some called social drivers of health. I mean, okay, what is it? I mean, all you need is another level of confusion to make it even more so. But I think the other part is, what's missing from the policy equation is, talk about studies, Ipyana, is one that would show how much the Older Americans Act saves Medicare and Medicaid. Okay, how much
Right.
these preventative programs save these other programs. Then you could take the savings and start plowing those back, and you wouldn't have to increase money. You would have money you could just redistribute. So we should be thinking about it. I think the MA space could be helpful in that regard.
But it is designated for health. And so prevention does move it way over and is harder to measure. So as we look at really trying to reallocate some of the medical dollars to social factors, I think it's disruptive and it's important because in a sense, pardon the food reference, we're moving someone's cheese. So whoever's cheese it is, it's going to be real to them. And so I do think as we do this, we have an obligation to think which are the drivers that if we can't feed everybody all the time forever, and we don't want to not feed anybody ever, somewhere in between is a Goldilocks zone. And in that zone, we can identify that really these are, for instance, 10 meals post-surgical discharge from the hospital. We can see somebody's debilitated, they can't get to the store, they can't cook. We can see that that's tied to healthcare and full recovery. So I think if we are in a process of discovery of if we have this factor, then our responsibility in driving to best population health in a sustainable way really does entail looking at targeting which people with which factors in their life at a point in time, which intervention, what duration, what dose, what frequency is the sensible investment that will allow us to really redeploy into a broader new social and health ecosystem that is sustainable and that meaningfully changes the way we address health.
Ipyana, you have to give that statistic that Meals on Wheels, one day in a hospital. You must put that out right now. I think that brings the point home very well.
When you think about the cost of providing a meal to a senior for every day of their life, every day of a year. Yeah, you put me on the spot, so now
Right.
I'm going to fumble the stat.
No, you got it.
It costs less than the cost of one day in a hospital for a senior. But one of the things
But does it prevent it?
But the thing is, we talk about post-hospital discharge meals, but nowhere do we talk about was malnutrition part of the reason why the individual ended up in the hospital in the first place.
Right.
And so when you have someone coming out of the hospital who is already struggling with nutrition, you're going to need to do more. So 10 meals might have been great had they been healthy, or clearly they wouldn't have been healthy because they wouldn't have been in the hospital. But it's making sure that you're aware of and looking at the totality of an individual, because otherwise you're putting Band-Aids over bullet wounds, right? It's like giving them 10 meals, that's
10
fine,
days.
10 days worth of meals, but you have a hospital readmission penalty of 30 days. Why are the incentives and the penalties not aligned? If you're gonna punish a hospital, why not provide the individual with those meals for that same duration of time? And that way, we can actually tell whether or not if that individual came back. I mean, especially 10 days, you don't even realize people come out of the hospital, they may not go home. So if you're a health plan and you're sending meals to a person's home and they're staying with a loved one to be cared for, they're not even getting those 10 meals. And that's if they answer the phone from a healthcare company or from a healthcare organization. I remember our chief medical officer when I worked at United said most people are nervous about answering the phone after a hospital visit because they worry it's a bill.
Mm-hmm.
And so they're not going to answer the phone. So if you're calling to try and let them know, oh, we have these great benefits that we want to offer you, they're like, I'm not paying that. I'm not picking up that call. Caller ID has been a downside. in many ways in terms of actually getting interventions to people because of concern and fear that people have and distrust that people have.
To get new benefits
That's
to
right.
people, you have to engage them and
That's
get their
right.
permission. It's proactive
That's right.
care as opposed to reactive care. So that's important. But then that's why I think we need to co-locate. So social care people on a targeted basis for those who can benefit can meet the person in the hospital, so you have eyeball to eyeball the opportunity to say, we have something that can be helpful and would you like it, and to arrange it before they leave the ER or the hospital or the nursing home to go home. I think those three major settings are big opportunities. It's not primary prevention, but once somebody is already in trouble, which America does then pay, if you wait and you're a wreck of the Hesper, then we will spend a lot of money on you. Then how do we then help take advantage of that opportunity to actually then help someone stabilize, achieve best possible health and independent living at that point, because we can find them. Finding people to address their social determinants or their social drivers, their health-related social needs is a piece of the work. Engaging and winning their trust is another. Then the intervention target, I think, is important.
Well, and you're prioritizing something that I was thinking about again on the earlier panel. I'm looking at Caitlin Saul-Redpath, who moderated the panel with Ali Reiser of ATI, and Ali was making the point about plans sharing information with seniors about the supplemental benefits available to them. And I just know at one point when my parents was in a Medicare Advantage, and she didn't even know she was in Medicare Advantage at the time till I was working in Medicare Advantage and told her. And again, that's so common, but she didn't know all the benefits that were available to her. But when Ali sort of made that point, it just did make you realize both who's the other messenger, and whether it's someone at the community level or could even be in this caregiver category, to communicate and help understand, your plan is sharing this information on these other benefits that you
Very
can
important.
access. But just starting with, are they going to pick up the phone? And then even when they do, sadly, maybe associating a plan with, depending on what aspect of the plan it is, the
Think
bill.
of yourself, and if your health plan calls,
Right.
is that a call that you're trusting and eager to speak with? Nothing against the plan, but I think there is this sort of social chasm, and so something more neighborly or something in person. I think if we can selectively embed social care people where, it's sort of, in a sense, it's maybe not a good example. If you went fishing, you'd want to go to the hole where the fish are. So if you want to find the people who
Willie
are
Sutton with the
social.
bank robberies, right?
Yeah, that's right. Go to the bank. Why do we rob banks? That's where the money is.
Right. Yeah.
But we have to locate the people for whom it's appropriate to add these services, call it to their attention, and see if they're willing to accept.
And that's a good point,
steps.
because I've seen examples where plans have gone to senior centers and held forums, held educational forums. People leave with materials. Older adults like to have something in their hand. They like to,
That's right.
we in our congregate nutrition part of the world, we often put tray liners on.
Right.
Like vaccine awareness or education.
Placemats.
Yeah, placemat. You put them right on the tray as they're eating their food, and they see that while they're eating, and then they take it home. So a lot of
Put
times,
it on the plate.
yeah, just let them break this divide down. I mean, you were talking about malnutrition a minute ago, and there's a quality measure that was adopted by CMS back in 2022 that we helped advocate for. It's based on if you get diagnosed with malnutrition and then the time comes to leave, you need to connect with a community-based nutrition program so you don't get readmitted. Well, there's a lot of hospitals and health systems that have any idea where the senior center is or where the nutrition program is in their neighborhood.
That's true.
They could be on the same street. So part of what we have to do in this world is start better communication, break those bridges down between people who have not talked to each other when they have common purposes.
Each of you in the work that you do with your organizations and your coalitions have a unique perspective. And again, supplemental benefits are a broad category, but I have to believe with some of the innovation, with some of these benefits, there's sort of a common thread that makes them, effective, and seniors can see the benefits of utilization. Can you sort of identify what you would see as maybe, a common thread for stakeholders of how they can see the benefit of the supplemental benefits for seniors?
I think data share is huge. Um, because at the end of the day, there are a lot of different things that health plans are doing, innovations that they're bringing to members in terms of coordinating their care after, ensuring that they're getting the doctor's appointments, trying to look at them whole person. But if they're not sharing that information or have the systems in place to receive information from those that they're partnering with, then it's just a nice innovation that may or may not have data to back it up to sustain the continuation of that innovation for the future. And so I do think that data share and incorporating, receiving, and sharing that data as part of their organizational a component of how they actually do business. I think too many times health plans are like, oh, we have care managers, we're good, we don't need that. But our members are in the home. We know what that individual looks like on a daily basis when they come to the door, or are they walking, are they struggling, are they do they have 5 flights of stairs to get up to their building, so they haven't left their house in however long, and so they're not going, even if you get them a car transportation, if they have to walk down 5 flights of stairs to get down there because the elevator in their building is always broken, then it doesn't matter. And so I think those are things that are necessary, because innovation alone is not going to keep these interventions around. There has to be data behind it, and there also has to be those organizations that kind of fill the gaps, fill the potholes in the road, so to speak, and identify them and make sure that they're filled so that the road can continue.
Two-way data.
That's right.
And where the data comes back to each party, and where, when we do pilots or we test some of these, we actually do it with a big enough group that the numbers will matter and have credibility, because data has to be believed, I think. And so it's very important to have the community data and the consumer, the patient, the person data getting into the healthcare provider community. I do think that it's beyond imagining what you actually see people are up against at home. And a lot of health professionals really have no way of knowing that. But as we begin to work more closely together, they can gain insight. Of course, they could be taken on a home visit. We're just taking our board members on a home visit coming up here, because nothing's substitute for really seeing what are the things that get in the way of what we would call, what causes non-compliance or non-adherence is massive and simple in terms of resources, environmental obstacles, and just knowledge, skills. So I think then measuring carefully is really, your point is a great one.
And I'll just add on the data side, it's also about a compilation of data. So if you start linking different things together, and this would fit in the supplemental benefit space, if you link nutrition with transportation, purpose transportation, I call it, which has a goal in mind, along with telehealth benefits to cut down isolation, and behavioral health, gather data on those kind of things and see where they connect to the whole person. And because a lot of people are dealing with need for more than one service. And usually if they find they need one, there's probably more that they need to have as well.
A good reason for the community care hub, by the way, because it is more than one service. And just as healthcare and a given service provider need to be connected, it really is more of an orchestra, if you will, that has to come together. And then language. So you were reminding me of a story Tim McNeil likes to tell about a guy who, and dialysis, he kept missing his dialysis, kept ending up in the ER, and they asked him why. And he said, well, I'm the first, I live way out here and I'm first on the list, so they try to pick me up at 4 in the morning. And sometimes I just turn over and I don't go. And he said, so what do you do? He says, well, then I call my other transportation company. Oh, who is that? 911. So you see, and for him, that drove a $500,000 health care expense package. And that was a solvable problem. You could change his appointment, for one thing. So, so these are powerful, and the information flow, the ability to come together and actually collaborate where appropriate in an efficient and effective manner about the care of high-risk individuals with solvable problems, pretty exciting.
We talk a lot about the need for stability in the Medicare Advantage program. And again, I spoke this morning about the policy changes that have been made in the program. And ultimately, this ends up impacting supplemental benefits. And so if you can speak to the need for stability in the supplemental benefits so seniors have consistent access to benefits and repeated care, and if that's an issue.
I'll take a crack at that first. I think there's two places I would go. One is on stability. We were talking about this before. Utilization is not a bad word. Again, it's got a bad connotation in some ways with some ideas that come out, and reporting has value, but it has limits. You can suppress good services by having too many reporting requirements, and I think having those kind of things can contribute to instability if they let it go too far. And I think the other part is from the community side, let's not create new infrastructures where you already have infrastructure that exists. Okay, if you want to have stability, take what's there in a community on the supplemental benefit side of all the things we were talking about, the different services. More than likely, there is somebody that's already there that could benefit from an MA plan coming in and helping them and providing what may be a new source of funding or just working more together. So there's no need to invent anything new. It just needs to be better relationships between the plans and the communities. And I think that will contribute a lot to stability.
Also, we do see these benefits change. And, we live in a world of IT high trust, but in a social world of low trust. And so where especially people with more complex situations and higher social care needs, I think it's very important that people don't experience broken promises where they finally come to expect something and then it gets taken away. So I think how we communicate about that, and to the degree that we could stabilize, make predictable, and maybe even, if not uniform, more similar, consistent things across the country and across plans would be useful.
I think there needs to be more deliberate conversations around on-ramps and off-ramps as it relates to benefits. And what do I mean by that? So someone who goes into the hospital and gets post-hospital discharge meals for 10 days, they don't understand why they're not getting meals after that point in time. And so our members are called because that individual is saying, hey, I still need food. And so then it's a matter of, okay, well, now a community-based organization is now having to take on this burden of caring for or providing meals for this organization that came to them through a health plan. And there may or may not be resources readily available. So that individual may go to the back of a waiting list for something that they clearly need but got exposed to because there wasn't a conversation of how are you communicating that benefit to the individual? And in the meantime, how are you assessing whether or not they have a nutrition-related need that is longer term, or that might have been the reason why they went into the hospital in the first place? And so without that conversation, because I don't know who they would have that conversation with.
That's what I wanted to ask you. When you say how you communicate,
yes.
Who's the you?
So when our members go to an individual's home, we don't just drop off the meals outside the door. We actually, there's an intake process that takes place because regardless of how they come to us through a health plan or through one of the programs, SNAP or OAA funding, there's an intake process that occurs with that individual. Because again, if the person doesn't answer the door, there are measures that you have to take to make sure that someone hasn't fallen on the inside of their home, and that we're not just going to look through and say, okay, we'll come back. And so there are processes and procedures that our programs establish So they know when that individual is receiving those meals, they know when they're home, they know how they look when they come to the door after their or during their recovery period. And they also know that when that individual calls them, that there's likely a real need there. And that's why it's frustrating for members, because they don't want to turn anyone away.
Mhm.
And when you think about that, the data that we were talking about before, typically there's no way for us to provide the findings that we have or that we're able to glean back to a health plan or back to a health system to say, we think this person might have a longer term need that you might want to think about, especially considering that there is a readmission penalty associated with this individual now after a hospital discharge. And so if there's a conversation around, oh, this person, do we know if this person has been in the hospital before? Are they going in the hospital again? Because most of the post-hospital discharge benefits are only one time. So if they go into the hospital, I know my father had gone into the hospital 3 different times during during a year because of nutrition-related concerns associated with his Parkinson's. And so when you think about that, understanding how to provide that total care to that individual to mitigate cost or to improve health outcomes, you really do need to understand what's going on in an individual more than just one point in time.
Mhm.
And you really don't have that information unless you have those coordinated conversations or that ability to share data and that consideration, again, of that on and off ramp for this individual. Like, what is it that we're trying to do for this individual? What does success look like with respect to patients with this profile or who go into the hospital this many times or who have these respective needs because they live in these communities that we do know or are familiar with? And then how do we bring in community partners or health system partners to ensure that they're not just kind of dumped by the side of the road after that hospital discharge period is over, but that there's a kind of the rest stop and someone else is coming to get them and they're going to get on that bus and go to the next place. And there isn't enough thought in the process of having some of these kind of conversations because we do benefits every year. And so by the time you get data on how somebody's utilizing the system, you're into planning for next year's benefit. And so it's a really short window. And so you're using snippets of data that are just at their organization. If you bought in community data, I can't even imagine how much longer it would take. So figuring out how to create more conversation and coordination amongst community partners is vital to being able to have those coordinated structures in place, that infrastructure that Bob referenced that's existing, that they're just connecting the dots to at that point. It's not that they're creating it, they're just getting information about it. So we can figure out how to stop Mr. Smith from going into the hospital 10 times a year because he's hungry.
Mm-hmm.
At a policy level, to your point, excellent points, we are starting to see the emergence of health information exchanges, which I think can be in the right direction and are very important. And we're starting to see, given that, 5% of people drive 50% of the health dollar, and knowing that duals are very important. And so Medicare Advantage and Supplement has a role to play and resources to bring, but we see a lot of states starting to step up around Medicaid redesign, and certainly in California, we're seeing things we thought we'd never see, including if a dual person, dually eligible, is in the hospital, it looks like now their Medi-Cal side can trigger a navigation under enhanced care management and eligibility for the in lieu of services benefits under the community supports program. So using that combination, we could follow that person post-acute with care coordination, and we could draw in the supplemental, the community supports Medicaid benefit to cover the cost of the waiting list for personal care and for meals until you walk through the wait list, because the wait list isn't eternal, it's just serious. Of course, maybe for housing it's eternal, but or almost eternal. So I think, this blending and braiding that's starting to be more the talk of the town is very important to look at who are the parties that should pay for which part of someone's care in order to actually get them to a place where they will be safe and be able to have a sustainable community living arrangement and better health, as best possible health.
Bob?
I'm good.
You
They,
are.
they covered it all.
June, you had referred to whole person care. And as we're looking at the reauthorization of the Older Americans Act, which I know you all are engaged on, and where BMA has been supportive, how can we look at that to be advocating for whole person care in the context of the inclusion or expansion of Medicare Advantage supplemental benefits?
It has created this wonderful platform of universally available, or at least comparable services across this country. So the Older Americans Act, its renewal and its expansion are critical for meals and a range of things. I think that it is one of the few places where we can get at what you both referred to, prevention. While in a sense you'd think the health plans and providers and health systems would want to look at prevention, they're actually mostly there for sick care. And so where is prevention going to come from? So this is a place. Title 3D is not the biggest portion, but that plus some of the new Medicaid can provide health coaching, especially under some of the approved evidence-based health self-management programs, which are powerful, underutilized, really can help people get a grip on how to get better health outcomes for themselves. So these aspects get to whole person because it gets to bringing people into social engagement, into congregate meals, into home-delivered meals, into activities, into volunteer service, into a range of things that the senior centers can bring that are so wonderful for people. I didn't understand that for a long time, but now I see that's really the country club for the average or the low-income person. It has all the benefits of a country club. And if we could just label it something so people who don't want to be called seniors could go there, we have to open that up. It's very important. But the ability to catch people at a much earlier stage to prevent falls, to manage diabetes before horrible things come of it, to address food insecurity, to manage chronic pain in better ways, to get people physically active, to improve every health aspect and to reduce the risk and progression of dementias. All of these are wonderful things that come from the Older Americans Act that I think are just so powerful and maybe not fully understood except by the people who access them, but this is a precious, precious aspect of our country's social policy and social investments. Other than that, I don't care about it.
I'd rather go, let me go to one part of the question about the Older Americans Act. It is beyond my comprehension how the House of Representatives hasn't even sent a signal of wanting to reauthorize the law that expires on September 30th. Not even a signal. And so to me, and meanwhile, the Senate has produced a bill that's a good bill, that's a workable bill that both reauthorizes and modernizes, and for the first time in the Declaration of Objectives includes a language related to health outcomes in the Older Americans Act, which shows the connection between the services in the Act and better health care. I think, what we should be talking about is how to make the MA community closer to the aging network going forward, because there is that connection that's there. And it
Natural marriage.
Right, it's a natural marriage, and there's where the word supplemental does make sense, because they can provide the supplemental benefits that the Older Americans Act cannot provide because of limited resources. So there's the marriage that we should be working toward, and I think we'll see good results if we go that route.
Well stated.
And I think
Bob.
most people don't realize that the Older American Act actually covers individuals age 60 and up. So it actually gets people before they enter Medicare. And I think that's to the point of prevention. If we're only going to fund sickness and not look further upstream, then okay, then fine. Then don't fund the programs that actually keep people out of the hospital, that can manage chronic disease, or that can make sure that something doesn't evolve to a point of a amputation. Like then continue to do what we're doing now. But if we actually want to improve healthcare outcomes in this country and we want to lower costs for the Medicare and Medicaid programs, then you actually have to fund and address the policies and update the policies and procedures of those social services that are providing funding and providing those supports earlier in those individuals' lifespans. And I think that's something that just is not connected as often as it should be. If you want to curb costs in the Medicare program, you have to look at those programs that serve those populations right before they get into it. Otherwise, you're not really interested in curbing costs.
I can't resist one more point, Mary Beth, which is that, if we're talking about this nexus and this closer relationship, it's off to a good start because according to what I looked up, 72% of MA plans offer meals at this point as part of a supplemental benefit, which is up from 67% just a few years ago. So you're talking about the largest program in the Older Americans Act. We already have a foothold in. So it's a question, how do you take that foothold, broaden it, and be complementary to what's already going out there? So I think that's where we should be striving.
And then coming to the community for that, because
Right.
there is a great deal of, as a new market arises in America, there's great interest. And so there's venture, there's retail, and yet we know Meals on Wheels actually knows the person, actually has a range of social skills, is surrounded and connected to all kinds of social service solutions that might emerge as needed or that might need to be prevented. And so this very whole person side is crucial. So I like your point. These are a natural marriage. We need to, we've invested across America in thousands of not-for-profits in all these great senior centers, area agencies on aging, but also many, many other kinds of specialty not-for-profits. And they're there for good cause and they need to be deployed. And so bringing those in, that's where the community care hub sometimes is of great value because it doesn't make them duplicate their infrastructure required to deal with the complexity of healthcare. But together, very, very important for really addressing these high risks, preventing decline, and improving quality of life for families. We heard about caregiving this morning, and these things are godsends for family caregivers as well.
Well, thank you, all three of you. And I think it's great sort of leaving that note of this marriage of the MA community with the aging community, but having it a marriage at the community level.
BFFs forever.
But I just want to thank Ipyana, June, and Bob for this conversation and discussion, and also just the value that you provide to our work in advocacy and education for the Medicare Advantage beneficiaries, but just seniors in general. And you can just tell from this conversation, your experience and insight and ideas. We're so fortunate to have it available to us. So
But we
thank you for
want to
sharing.
commend BMA for all the inclusiveness of the program at this conference as well, because you're on the cutting edge of this emerging new partnership. So thank you for your leadership.
Oh,
Thank you very much.
Thank you.
Okay.
Thanks, everyone. Let's please.